charla, el doctor Huser. Hi, Dr. Huser. Nice to meet you.
Hello. Can you guys hear me?
How are you?
Good. Thank you.
Thank you.
So I've got a presentation, and then I think it'll probably take like 15 to 20 minutes, and then I'll answer any questions that people have. You just want me to share my screen?
Okay. One moment, please. Yes, you can try it. Okay.
Is that?
Yes.
You see that?
Yes, that's perfect.
Okay. So
my
name's. Yep.
Okay. Sorry, doctor. Yes. We want to start to make a short, brief presentation about the talk about you, and then you can start if you want. Yeah. Okay.
Yep.
Thank you.
Yep.
Sorry. Bien, bueno, pues nada, daros la bienvenida a todos, buenas tardes, buenos días para algunos de los que estáis asistiendo a esta charla por la diferencia horaria. Daros la bienvenida en nombre de la Fundación ALPE. Bueno, yo, para los que no me conozcáis, soy Susana Noval, soy la coordinadora de la Fundación, pero aquí nos acompaña todo el equipo, algunas podéis ver, otras no, porque ya sabéis que este formato es charla, ¿no? Es seminario, no es reunión, pero está con nosotras Carmen Alonso, que es la directora de la Fundación, Estefanía González, que es la directora de proyectos, y Sonia Sestelo, que es la secretaria. Bueno, sabéis que esta charla es la segunda de este ciclo, forma parte de un proyecto que, bueno, como explicamos en la anterior charla, es un proyecto que creíamos muy necesario por parte de la Fundación, que es, bueno, pues un poco la divulgación del conocimiento, de las buenas prácticas y sobre todo hacerla llegar a las personas interesadas, tanto a las familias como a los adultos afectados, incluso a los profesionales que en su día a día trabajan con lo que denominamos nosotros las ADEE, ¿no? Las Achondroplasia y otras displasias esqueléticas que causan enanismo. Bueno, básicamente porque todos sabemos que están dentro de lo que son las denominadas enfermedades raras y evidentemente muchas veces tenemos problemas para acceder a esa información, para acceder a ese conocimiento, para acceder a esos expertos, bien porque a veces hay poco o bien porque el que hay, bueno, pues los canales no siempre son fáciles o accesibles para todo el mundo. Entonces creíamos necesario, y más en los tiempos en los que estamos, ¿no? En los que tampoco puedes desplazarte al centro de referencia muchas veces o a las consultas o tener un contacto directo con el que necesitas, creímos necesario que este proyecto siempre, ¿no? Siempre hay que tenerlo ahí, pero más en estos momentos. Así que, bueno, pues nos proponemos a lo largo de todo este 2021, si fuera necesario alargarlo más, pues también lo intentaríamos, realizar diferentes charlas abarcando los temas más importantes que conciernen a las ADEE. Y siempre, como siempre hablamos, desde una perspectiva integral, desde una perspectiva global de lo que es la persona, ¿no? Con ADEE, pues habrá charlas de contenido clínico, de contenido científico, abarcando también la investigación, este tema ahora tan importante y sobre todo de tan actualidad, también el ámbito educativo, los derechos sociales, bueno, un poco fiel al trabajo que la Fundación hace, ¿no? en el manejo de las ADEE, en el trabajo de soporte a las personas y a las familias y nunca olvidándonos de los profesionales, bien porque nos sirven de expertos como el doctor Huser hoy, bien porque hay profesionales que también necesitan llegar a ese tipo de información y ese tipo de conocimiento porque en su día a día trabajan con las personas con ADEE. Entonces, sin más, porque no queremos robar tiempo realmente al protagonista de hoy, paso a presentarlo. Bueno, habéis visto que a través de nuestras redes sociales y del email hemos ido presentando varios días al protagonista, al experto en este caso, es el doctor Huser. Él ahora mismo trabaja dentro del equipo del doctor Paley y el doctor Feldman en el Instituto Paley en Florida. Él ya se formó hace unos años, ¿no? Al principio, cuando se iniciaba en todo este campo. fue becario y se formó de las manos de ellos dos. Posteriormente trabajó en otros hospitales como el Gillette Children's Healthcare, y ahí fue donde más se especializó en la corrección de deformidades de las extremidades. Pero bueno, quizás también por su deseo de especializarse y de atender a pacientes de todo el mundo y de intentar buscar nuevos tratamientos, nuevas soluciones, nuevos manejos clínicos, nuevas prevenciones, que al final también es importante, ¿no? Analizando bien las necesidades y las demandas de esos pacientes, escuchándolos y viendo de manera individual toda su patología. Retornó al Instituto Paley en Florida, del que ahora forma equipo con el doctor Paley y el doctor Feldman, entre otros, al que nosotros sí que tenemos el gusto de conocer personalmente porque han asistido a nuestros congresos internacionales. Al doctor Huser personalmente no, pero sabemos que contaremos con él en nuestros futuros congresos. Sin más, darle la bienvenida, decirle que para nosotros es un verdadero placer y un honor cortar con expertos de su categoría y de su nivel, y que tan altruistamente y sobre todo de tan buen agrado siempre acceden a participar y al estar al lado de las familias y al lado de las personas y de los profesionales que lo necesitan. Así que muchísimas gracias, doctor Huser, y cuando quiera.
Right, thank you. My name is Dr. Huser. I'm a limb deformity and limb lengthening surgeon. As she said, I'm partners with Dr. Paley and Dr. Feldman. We have a couple other partners too. Last week, Dr. Feldman presented on back pain and spinal stenosis in achondroplasia, so I won't be talking about that. I'll be talking about pain and lower limb deformity today. I don't have anything to disclose. I don't have any influence in any companies at all, so I'm not trying to sell anything. So pain, patients with achondroplasia that we see, a lot of them come with pain, some come with deformity. What we can't forget are patients with achondroplasia are just, they also have normal problems like strains and muscle soreness and sprains and muscle weakness, and they also get fractures. But probably the best thing to do without going to surgery is staying active. Even with achondroplasia, activities like swimming and biking, which are low impact on the joints, can do wonders for preventing some of the pain that we have just from everyday life, including the back pain that you get. However, patients with achondroplasia also have different problems, and those are related or can be related to the alignment of their lower limbs and the stability of their joints. These are two x-rays of two patients with achondroplasia, one showing bow legs, which is more common, and the other showing knock knees, which is not as common, but also can happen with achondroplasia. So places that can hurt in the lower extremities, I've circled them here: the hips, the knees, and the ankles. And the way we go about diagnosing those problems are to take each joint through a range of motion when we examine you, push on the different areas, test your strength of the muscles that surround those joints, and then assess the stability just by doing some provocative testing. We also get x-rays and occasionally MRIs to see, the status of ligaments or tendons, things that we can't really see on x-ray. Then we come up with a diagnosis. And what I'm going to do now is go over the different diagnoses in achondroplasia, mostly affecting the knee, but that can have some effect. So first off is bow legs, or what we call in the medical field, genu varum. This is an x-ray of a patient without achondroplasia. And that line that I've drawn here is a line that shows the center of the hip down to the center of the ankle, which is how gravity affects our body and the force that goes through our body. Ideally, that line goes through the center of the knee so that the force and your weight is goes equally through the knee. Now here's a patient with achondroplasia, and when I draw that line goes on the inside of the knee. So the force that the knee sees in this patient with achondroplasia is all on the inside of the knee and not equally spread through both the outside and the inside of the knee. And the concern with that is that this patient is going to likely go on to develop arthritis within the knee, which can be a debilitating and painful condition. The patient on the right of the screen, the one with achondroplasia, is a child. And we know that because we see growth plates at the top of the hip, at the bottom of the femur, the top of the tibia, and the bottom of the ankle. And how we treat this type of deformity, or these bowed legs, can differ between patients who are still growing and patients who are done growing. In this case, because this patient was growing, we did something called 8 plates, which is just a small incision. The plate is placed and then 2 screws. And this uses the patient's own power of growth to slowly correct the bow legs. And you can see here that after correction, that line that originally was going down the inside of the knee is now going down through the center of the knee. And so those forces are spread out equally. And hopefully this patient will be less likely to develop arthritis. He still had, at the time of this x-ray, he still had these plates in, but we routinely take these plates out. For an adult, we do different types of deformity correction. And here we've cut the bone and we've realigned it so that we get our line right down the center. You can notice that the picture on the left, there are no open growth plates here or up at the hip. And the line goes on the inside of the knee. Not as bad as the original patient that I showed you. We see that once we correct those deformities by cutting the bone gently and putting these plates on, now the force that the knee experiences is right down the center. I think that the adult patient and the pediatric patient are a little bit different. The pediatric patient or the younger patient likely won't complain of pain because they still have good cartilage. But the adult, as their cartilage starts to take more of this force, may complain of pain. So sometimes we do these different corrections before patients even have pain in the hopes to prevent pain from occurring. The next problem that is common in achondroplasia is knee instability, and it's due to this high fibula. And I'm going to show you an example of, again, a patient without achondroplasia. This small bone is called the fibula. The larger bone is called the tibia. This fibula is located where the growth plate used to be. Now, if we look at this patient over here, the fibula is actually at the top of the knee joint. And I'll show you why that's an issue, but I just want to illustrate this a little bit better. Here I've drawn the 2 lines. The red line is where the fibula should be about. Here's the top of the fibula. And then in a patient with achondroplasia, this is where the fibula should be, but it's migrated up here. And there's a ligament that attaches to the fibula called your lateral collateral ligament. Now, this is an example of, the picture on the right is showing a torn lateral collateral ligament. But the lateral collateral ligaments in achondroplasia aren't torn, but they're loose. And when they're loose, you can see the different gap. On the picture on the left, there's no gap between the femur, this top bone, and the tibia. When it's torn or when the ligament's loose, there's a large gap. This also contributes to bow-leggedness and contributes to instability. Instability is one of the #1 reasons people develop arthritis with or without achondroplasia. And so when you have that instability, that can cause pain and it can cause your knee to give out. So here again, we have the patient with the left knee where the fibula is higher than the tibia. What we do for this is we actually lengthen the bone and drag the fibula down to the right position. So again, I'll show you that same picture. Here's where they started with the fibula too high. It should be at or below the level of this red line. And then after we lengthen the tibia a little bit, it actually drags the fibula down so that the fibula is at the level of the growth plate. That's anatomically where it should be. And in doing so, you've created tension in that ligament so you don't have that instability of the knee. So that's one reason why the knee can give out. It's also a reason for pain. Another reason why the knee can give out is because of, this is a sideways view of a patient with achondroplasia. And this is not how the knee should look on a sideways view. The tibia here is actually subluxed and almost dislocated in the front. Again, here's a patient without achondroplasia. This is that same x-ray, and if we draw a line, this line goes right down the front of the tibia, almost down the center, and here this line is going in front of the knee, which gives this patient experience instability and can also have pain in that area. So to take care of this problem, again, we can zoom in, you can see how close that is. That's nice and aligned with the tibia. Here, if I would draw a line, it actually goes behind the tibia, which leads to hyperextension and instability, the knee giving out. Again, this can all cause pain. It can cause anxiety. But what we do is we actually cut the bone at the knee. We cut the bone at the tibia. So this, again, the femur we cut and the tibia we cut. We place the plates with the correction. And you can see that we draw that line from the center of the hip to the center of the ankle. Now, excuse me, this line is going right down the center of the knee, and this line's going in front. So we've corrected that deformity. It takes away the feeling of instability, and that feeling of instability can actually manifest itself as pain too. So we have these options for treatment. We have these solutions for these problems, but there are things that we have to be cognizant about, and that's infections can occur with any of these operations. It's why we give antibiotics before surgery and after surgery. There's the chance that the bone may not heal. And so we also choose to, sometimes we put in a little bit of supplemental bone to help with the healing, help with the biology. Probably the biggest concern we have before ever performing a surgery like this is that this isn't going to take away the pain that you're having. And this goes back to the talk that Dr. Feldman gave last week, in that pain can also come from the low back. And it's really important to investigate the low back or the upper back with an MRI to make sure that we're not having any nerve root impingement, which can masquerade as knee pain or hip pain or ankle pain. And lastly, because we're making incisions on the body and we're manipulating things, there's always a risk to damaging nerves or blood vessels. At the Paley Institute, we like to be very careful and actually find these structures before doing any corrections to make sure that they don't get injured. The take-home points with this is really that there's a lot of different reasons for pain. Some of them are just as common as that patients have without achondroplasia, but there are also specific ones that affect patients with achondroplasia. And those three things are bowed legs or knock knees, knee instability due to a longer fibula, and then knee instability due to incorrect anatomy on the side, or what we call sagittal plane malalignment. There are specific causes, which I just went over, and that non-operative and operative interventions exist to help care for these. People don't need to live with this pain, with the deformity, or with the instability, and we can do things to help out. The non-operative treatment, like I mentioned just briefly, is really exercise, staying fit, and the best things to do for anyone that has joints that may be at risk of instability or arthritis are low impact exercises such as swimming or biking. I'm happy to take any questions. My email address is there. Please send me an email if you have any questions in Spanish. It's fine, I can translate it, or in English. Either are okay, and I'll be happy to get back to you as soon as to answer your question as soon as I can. That's it.
Ya. Bueno, pues muchísimas gracias, doctor Huser. No sé si queréis en el chat preguntas, respuestas o levantar la mano. Voy a chequear un poco lo que hay aquí. Sí, a ver. Bien. Yo creo que sí tenemos alguno. Pepe, quizás. A ver. Bueno, una de las preguntas, doctor, es ¿el plasma rico en plaquetas es una opción válida para tratar los dolores en las articulaciones?
What is that in English? I'm sorry.
I'm sorry. I thought that Laura can translate or yes. Yeah. Yeah. Can you use the other channel in translator? Yes, in your computer.
No, the translator on my computer.
Okay.
I'm trying to find it. I'm not sure if I'm just because I thought I turned on the translation, but then I don't think I have.
Pues,
I'm gonna.
sorry.
So I'm gonna stop my share real quick. Interpretation. All right.
Down in your computer, in downside, on the right, maybe.
Yes, I can hear the
Do you
English
find
channel.
it? Okay.
Okay, so what was the question?
Yes.
Plasma.
Yes, controlling. Yes. Vamos a ver. Bien, decían que sí, el plasma rico en plaquetas es una opción válida para tratar los dolores en las articulaciones.
So the evidence for platelet-rich plasma is mediocre. I don't have any experience with it going wrong. And patients do say like, look, I feel better. So I think it's reasonable to try it and you don't burn any bridges. But I can't say like, yes, you'll absolutely get improvement if you're having pain, if you get a PRP injection. Does that make sense?
Sí, perfect. Yeah.
Okay. And then what was...
¿Qué opinas sobre las prótesis de rodilla? ¿Qué opinión tiene al respecto de ellas? En el caso de ser necesarias, ¿no?
Yes, I think so. You know, I don't do total joint replacement, but absolutely a knee replacement is a wonderful option in the right patient. And that right patient is usually older, because what you don't want to do is you don't want to go through life and have to have 3 or 4 knee replacements. You want 1 or 2, and they last somewhere between 10 to 20 years each knee replacement. And so an ideal age for someone to get their first knee replacement would be at youngest maybe 40, but ideally 50 or 60 would be a good age to get a knee replacement. But it's a wonderful operation for taking away pain, especially if you have too much arthritis, to do a reconstruction using your own body parts.
Aquí tenemos otra. En caso de un gen varo pronunciado, ¿a qué edad es aconsejable la intervención paliativa para alinear la línea tobillo-cadera?
You know, that's a great question, because there may be some recurrence when you do the 8 plates, which is sort of a minimally invasive technique that I first showed with the young patient with the bow legs or the genuvarum. I think around age 6 to 8 is a fine option to do it. You know, that way you have better visualization of the epiphysis as well, which is just above or below the growth plate. And the plate and screw constructs fit a little bit better, but I think 6 to 8 is a good age. And same thing with the genu valgum or the knock knee. You can also fix that with guided growth, which is an excellent option. In achondroplasia, pseudochondroplasia doesn't work as well, but achondroplasia, I think 8 plates are a fine option. And again, you don't burn any bridges with it, so.
Bien. Aquí hay otra que dice, deseo preguntar si el tratamiento de elongación ósea podría tratar estas alteraciones en la alineación de miembros inferiores y a qué edad recomienda hacerla.
So, yeah, patients with achondroplasia usually end up in the US around 5 or 6 standard deviations below sort of average height. you can absolutely use lengthening. And I purposely didn't talk about lengthening in this talk as much because I wanted to focus just on lower extremity deformity, but I'm happy to answer any questions about it right now. We tend to, most patients where we do deformity correction, we do tend to lengthen them, and it's actually, we less often just do deformity correction. Usually the start is between 8 and 10 years old where we do the lengthening, and we try to get a fair amount of length, about 5 centimeters in the tibia, 5 centimeters in the femur at each lengthening, with a goal to get them in the lower 5% of average height by the time they're done growing. And hopefully then that will be best for their life. And this can all be accomplished before they start going on to college. You can, if you're using a frame, which is a device that goes on the outside, which is also to my shoulder that I'm pointing to, or you can use a nail on the inside of the bone to do the lengthening, but you can also do deformity correction with that. If you're going to lengthen both the thigh bone and the shin, the femur and the tibia, we're pretty strong advocates of also decompressing the nerves around the knee so that they don't have a problem. Some patients will develop a foot drop, and that, you know, that's a devastating complication for a patient again. So we try to prophylactically or preventive do it with to prevent that from happening. But yes, you can correct deformity and lengthen at the same time. And the only thing is, you know, the patient who's undergoing lengthen should be able to be part of that discussion. And sometimes it depends on their intellectual maturity and how much they understand, because this is a big operation. It's 12 weeks usually of lengthening, and then another 12 weeks of where it's healing, or 8 weeks of healing. So it's a long time. And we like to have our patients also be involved in that decision making when they're going to go forward with something like that.
Gracias. ¿Podemos algunas preguntas más, doctor? ¿Tenemos tiempo?
Of course, I have plenty of whatever you guys want to do. I'm happy to ask whatever or answer whatever. I've cleared my schedule.
Muchas gracias. Mira, aquí hablan que para los adultos, ¿cuál sería como la edad límite donde usted recomienda esa corrección de las piernas y todo el tema de rodillas? ¿Hay una edad límite en la que dices hasta aquí, o cuando ya tienes esta edad y ya no puedes pasar por esta intervención de corrección?
So age is a funny thing, because we all, you know, someone asks you how old you are, you tell them a number, but you look at them, you're like, wow, you look 10 years younger, you look 20 years younger than that. And it seems to, you know, as you get older, sometimes you see someone who's 60 years old but may look like they're 50. I would say that the limits aren't so much age, although if a 60-year-old wanted an acute correction, I would probably recommend for a total knee, because there's more likely arthritis in the knee. The reason where I'd be less likely to do the bony correction as opposed to a total knee is that they have arthritis already that is severe, or they have problems with bone healing, and that can be from age. If they have a bunch of chronic medical conditions, diabetes, if they're smokers or they vape, I wouldn't want to do a bony surgery because it's not going to heal, or they're at a higher risk of infection. But doing this in a 40-year-old, I recently actually did one of these in a 44-year-old, and she healed great. And so it's okay. And she's, you know, she's a younger person, and that's what's more important than just the number. But I would definitely question 60 or maybe even 55 versus just doing a total knee replacement. That person is likely to be fine with their total knee for the rest of their life, especially if they've gone 50 years already with deformity within their knees or legs.
Mira, aquí hay una pregunta sobre el dolor. Dice que para dolores de rodilla y tobillo de un niño de 4 años, durante la noche, ¿tiene alguna recomendación de cómo paliarlo?
You know, you have to get an x-ray first. Usually, so if a patient like that comes into my office, I will, like I said, do an exam on them. And usually for, there's growing pains is this ambiguous diagnosis. I don't really like it because it's just sort of saying like, I can't figure this out, but it's, we don't know what it is. But usually I will take their joints through a range of motion. I'll push on their ankle, push on their knee, try to see if it's loose at all. And then I have them get on the floor and I have them jump up and down. I tell them to explode up and touch the ceiling, give me high fives. If they can do those things, it's usually nothing. If they can jump, there's not something structurally wrong with their bones or with their muscles. If they're having pain with that, I think that's a good reason to get an x-ray and perhaps even get an MRI of the knee or ankle. But if they're running around and it's just at night, night pain is a red flag for surgeons and for physicians that is there something like a tumor there, because tumors tend to cause pain at night. Other signs of tumors are weight loss, loss of appetite, and you can't really see those on x-ray. But if they're able to jump around, I'm less likely to be concerned about it, and also would consider inflammatory diseases or autoimmune diseases and potentially have them seen by a rheumatologist as well. But usually to be honest, kids rarely complain of pain. It's mostly a structural deformity that we're trying to prevent them from having pain later in their life and preventing damage to their joints and cartilage. But that's how I would examine that patient and then make recommendations based on that.
Gracias. Mira, relacionado con el dolor, aquí hay una pregunta que dice que es, bajo su experiencia, si hay una edad en la que usted sabe que puede empezar a aparecer el dolor, en el que diga, mira, a partir de esta edad estar alerta o estar atentos porque sí que puede, bajo lo que he visto, que puede empezar a aparecer esos puntos de dolor. ¿Hay alguna edad de referencia?
So it's mostly like as they gain more weight and maybe they don't have the muscle structure to support the weight, so now the joints are bearing more weight. I think after 9 or 8, and then into adolescence is when you get it. But like, it's rare to have a 6-year-old that hasn't broken a bone complain of pain. And that's just because they just want to play, and they'll go out and play and they'll have a good time. And then maybe they don't want to go to bed. Maybe they're afraid to go to bed. So that's where that whole growing pains things comes into. But I try to take those complaints, even when parents are like, oh, they're having pain at night. I take them seriously and usually offer them an MRI, which is probably a little crazy on my part, because I like them want to make sure they are okay. But yeah, like 8 or 9 is where I would look for more things.
Está bien que saque, doctor, el tema del peso. Nosotros desde nuestra organización hacemos muchísimo hincapié desde el nacimiento porque, bueno, está demostrado que los niños y los adultos con achondroplasia sí tienen una tendencia a tener un sobrepeso, ya por la propia mutación del gen, evidentemente va en su propia condición, pero sí que tienen que tener una alerta desde el nacimiento de que esa patología existe y que eso le va a traer no solo un tema estético o no estético, es un problema que va asociado a muchísimos problemas. En este caso, pues el que, relacionado con el tema que usted ha dado en la charla, yo creo que tanto el dolor como las deformidades, ¿no? Creo que el peso es un factor, si no el más importante, pero clave, ¿no?
So this is interesting. I've had this conversation with Kristen, who I think you introduced at the beginning, but I couldn't understand because it was in Spanish. But I've been thinking actually of trying to produce and having some of our patients participate in like making some exercise videos for patients with achondroplasia, with pseudochondroplasia, with dystrophic dysplasia, of exercises that they can do safely to help reduce their weight and to prevent weight gain. Because I mean, your knees actually experience like 5 times your weight when you're walking upstairs and running, and your hips do too. So if you take off a pound, your knees are experiencing 5 pounds less. I mean, it's crazy. And so all for that initiative. I think it's really good for prevention. Now, granted, if you're overweight plus you have deformities, you're going to feel more pain, and you'll need to lose more weight if you're going to say, like, I'm not going to change the way my legs are. You'll actually have to lose more weight than someone who has straight legs, because you're putting all that pressure across a small area versus a larger area. But yeah, I 100% agree that weight is a problem. And there are things that do with their bones are not the length that their muscles want to be like. So sometimes it's not as bad as we think. But I've definitely thought about creating an exercise regimen for patients with achondroplasia, for exercises that are safe, that are not asking them to do crazy movements, but are keeping their heart rates up and keeping their weight down. And I think that, sorry, last thing, I think that would actually help with their back, with lumbar stenosis too. I mean, lumbar stenosis and achondroplasia is very real, but having a strong core will help prevent some of the problems that are associated with it. And maybe it can decrease their need for surgery. I don't know, but because I mean, we also have some very fit patients that we've taken care of that still require it due to pain and due to issues with their nerves and stuff.
Desde luego, nosotros insistimos mucho en el ejercicio físico y sobre todo también en la alimentación. Necesitan saber que tienen una alimentación adecuada para ellos, para su peso, para su constitución, para su condición, y que además, bueno, pues la alimentación también es un tipo de educación, y que si se educa desde el nacimiento y desde el principio siempre va a ser beneficioso, ¿no? O sea, que tiene mucho que ver también con esta patología. Bueno, yo creo que podemos unas cuantas más, tampoco hay muchas, pero o sea, no queremos tampoco abusar mucho de su tiempo. Pero aquí pregunta, mira, si la osteopatía o la quiropraxia la recomiendan desde el nacimiento, ¿puede reducir los dolores y desviaciones, ese tipo de técnicas?
Yeah, so just one last thing about the weight gain and the food. I actually think that if parents work out with their kids are going to do it. If the parents, they have to do it together. This isn't like, okay, I'm going to watch you, you're going to do 10 jumping jacks. If you make it a family activity for 30 minutes or 45 minutes a day, these kids will join in. And then when they're adults, they'll have that ingrained in them that they'll want to do it too, and will stop the cycle with overweight. And I just think that's so important, that like working out as the parent of that child is just as important as that child working out. In terms of chiropractor manipulations and stuff, I think it's fine. I don't think it will correct any deformities. This is an issue with how their body is and how their growth plates work, which is also why we get recurrence when you do the 8 plates in younger children. However, for pain, I think it's fine to try it. Now, if you have pain where you get a electric field down your leg, which is an obvious nerve root that's being impinged, probably not the right idea to go to a chiropractor. But low back pain, absolutely go for chiropractic work. If you're having near hip pain, you can try it. If it doesn't work, it doesn't work. They're not going to cause more harm, but it may work for you, and that's important. I think massage is a really good thing for people to, especially when they have maladaptive movement patterns in their body due to mechanical misalignment. I think massage is great as well.
Muy bien. ¿Alguna recomendación para dolores articulares después de hacer deporte, por ejemplo, natación, en un paciente ya de 40 años? Si algún tratamiento después de hacer ese deporte nota dolor, ¿alguna recomendación?
What joints hurt after swimming?
Pues como nos lo ha dejado escrito, si quiere levantar la mano.
Okay.
Con el nombre no sabemos muy bien quién ha sido. Bueno, vamos a pasar a la siguiente y si quiere este espectador que ha dejado la pregunta, levantar la mano y matizar un poquito qué articulación es la que le duele para poder dar una respuesta más concreta, pues que lo haga. Aquí hay otro que sí que dice, soy Raúl Micos, un adulto de 40 años, muy deportista, a nosotros nos consta que le conocemos, con artrosis de cadera y le han recomendado una operación de prótesis de cadera. Ahora no tengo mucho dolor, pero evidentemente no puedo correr. ¿Qué me recomienda hacer? ¿Paso? ¿No paso por quirófano?
Okay, so there are a couple things. Not having pain is, if it's interesting that you got an X-ray because you don't have pain. And the real reason to do a total hip replacement is to take away pain. Now, the other reason is if you don't have good motion at your hip. So if the reason you can't run is because you're weak, that might, and I'm not saying you're weak, it sounds like you're a very fit person, but sometimes the way that your bones form, they actually disadvantage your muscles. Without looking at your x-rays, it's hard for me to give you a reason to get to say yes or no to that question. But I think a big question for you is to ask the people what they think you're going to be able to do once you have the hip replacement, because there are sometimes restrictions after replacement surgeries that aren't there if you do bone cutting surgeries. And from the sounds of it, as a 40-year-old and a young person, you may be, depending on the quality of your hip. If I would see an x-ray and your hip is completely full of arthritis, yeah, it's hard for me to recommend a bone cutting operation because it may actually cause pain and it may load your joint differently to where it's painful now. But it's surprising that a total hip is the reason why they want to do surgery on you when you're not having any pain. And so I have to assume that you're having pain or you got the x-rays because you're lacking motion or you're having some weakness somewhere. And maybe if you want to, we can go on to another question if you can answer that stuff in the sidebar, like why you saw these guys, not just what, or guys or gals, but why they recommended a total hip. And again, I'm happy to look at, if you want to email me your x-rays, I'm happy to look at those and take that conversation offline with you too.
Perfecto. Sí, eso le iba a sugerir. Nosotros siempre que intentamos no abusar mucho de siempre de tener expertos tan fantásticos y tan disponibles. Quizás en algunos de los diagnósticos que aquí podemos tener duda, sí que a veces pedimos la colaboración y bueno, este puede ser un caso en el que si Raúl nos envía todas las pruebas, podemos hacérselas llegar y que este chico quede un poco más tranquilo. Dicen que hablando de deporte y no pudiendo hacer bicicleta, que entiendo que es lo que normalmente hacía esta persona, pregunta qué tal estaría andar en la cinta de correr, ¿no? Si se puede andar en esa cinta estática y si se puede y lo aconseja, ¿cuánto tiempo sería recomendable?
So absolutely, you can use a treadmill. You can do anything that doesn't cause you any pain. Sometimes the most common reason for knee and hip pain is usually muscular deconditioning, so that your butt muscles or your thigh muscles are weak. Or sometimes it's your belly, your abdomen, your abs are weak, or your low back is weak. And you can really do any exercises. I think the best exercises for strengthening the core are planks. I'll just type that in the chat room, and planks help strengthen the core without you having to do a sit-up. And a lot of people with back pain or with hip pain, they don't want to do sit-ups. And so planks will help you get that first step of strengthening your core. And then simple things like squatting. Squatting without a bar, just with your body weight is wonderful. It's low impact on your joints. That's great too. And it's important to even watch some videos on proper technique so that you don't hurt yourself. But really, when you're using your body weight, you shouldn't have much pain. Walking on a treadmill is great. Anything that will get your heart rate up is good for losing weight. It's good for your heart. It's good for your lungs, and you're going to develop muscle. Walking is probably the least of the exercises that will develop muscle, because a lot of walking is just balancing on bones versus having to flex your muscles to maintain a position. And so that's why I think it's fine. It's a good exercise. And if that's what you can do, please do it. But other good things that get your heart rate up and things to start with are something with planks. Even if you do them on your knees and elbows as opposed to your toes and elbows, it will help you, and you'll get stronger and you will feel better. I can't emphasize that enough.
Sí, todo lo que conlleve, que entiendo que pone aquí, lo que no conlleve impacto, ¿no? Lo que te haga ganar, sí que es verdad, potenciar la musculatura y con el mínimo impacto posible, ¿no? Que es un poco lo que recomendamos también desde nuestra organización. Sí que estábamos pensando, doctor, en hacer una infografía sobre el ejercicio físico y el deporte a modo de recomendación y protocolo. Entonces, quizás también vayamos a contar con su colaboración para poder validarla y poder hacerla extensible, porque sí que es verdad que recomiendas actividad física, pero muchas veces si la haces mal es más contraproducente que si no la haces, ¿no? Porque hay veces que vemos unas actividades que no son recomendables para la condición específica que se tiene. Entonces, quizás hacer una infografía en el que a nivel un poco general se hagan unas buenas recomendaciones sobre qué tipo de ejercicio físico, incluso deporte, tiempos, ¿no? Un poco de orientación sería adecuada, ¿verdad? Para tener un poco de referencia. Así que contamos con usted.
I love it. I think it's wonderful. It's what I want to do.
Aquí hay una última pregunta. Soy una mujer de 37 años. Suelo nadar 3 veces por semana 1 hora y camino o bailo 15 minutos los demás días. ¿Qué me recomienda para el dolor de espalda que a veces tengo después de hacer esta práctica deportiva?
So, this goes back to the presentation I was given last week. It's really, where is your back pain just in your low back, or do you have pain that travels down your leg? If it's traveling down your leg, I would advise you to get an MRI, because there's a good chance that you have lumbar stenosis that's impinging on a nerve root, and it's good to get it taken care of. The issues with lumbar fusion and the surgeries that we do for that is it really stiffens up the back. So if it's just low back pain, things that I would do, I would start with the planks, and then I would do another exercise called like a Superman or back extensions, where you lay on your stomach and you lift your chest and your legs off of the ground. And that's another thing to help with low back pain. Again, some of these things are specific, like where's your back pain? What exercises are you doing? If you're doing weighted exercises like deadlifts or squats, I would tell you stop those for right now, because your body's telling you that you can't do that yet, but you might be able to work up to that over time. I think really getting to the basics. I love that you're dancing, that you're swimming. I think that's really wonderful. Swimming's a really good exercise. Going back to the other patient, if that person was having shoulder pain, the only thing that I don't like about swimming is it can really show us laxity within the shoulders. You just have to do some exercises before swimming to strengthen that. But if your back pain is, again, please feel free to email me and just give me more specifics on when you have your back pain, and if I can tell you if I think you should do something more. But I would start with planks, and those are called isometric abdominal or core exercises. And the reason I like those is because it doesn't cause a lot of movement. You're strengthening without the potential for injury.
Bueno, yo creo que nada, una última pregunta. Mira, hace tiempo me recomendaron uno de estos aparatos de gimnasia que vibran para perder peso. Pero he oído que esas vibraciones a los huesos son malas y me gustaría saber si esto es cierto. Bien, eso va un poco a lo mejor a veces esta gimnasia pasiva, ¿no? Que no sabes hasta qué punto, sobre todo cuando utilizas aparatos, ¿no? O mecanismos, porque la gimnasia pasiva también puede ser tirarte en el sofá, ¿no? Pero bueno, si hace alguna recomendación sobre esto último.
So, I mean, you know, vibrations are not actually harmful to bone. In fact, if you had a fracture and you kept vibrating it, that might be a problem. Or if you're like shaking your fracture, that's a problem. But we do use devices that send pulses to the bone when we can't get bones to heal, actually, to help them heal. And there's a level of motion that the bone wants to see, actually, to help it grow and to help it heal. But vibration as your form of staying fit or losing weight or building muscle, again, we do use some electrical stimulation stuff to build muscle. It's not really the way I would go with trying to exercise. And I'll tell what I just had a thought. No, I just had a thought in my head, and I'm not sure if I should say it, so I'm going to.
Claro que sí.
So, you know, people wear the watches that tell them, oh, you have 10,000 steps, you're good, you don't have to exercise for the day. And I have family members that wear those, I have friends that wear them, and every time someone shows like, oh, I got my 10,000 steps, I'm like, you don't need to have a machine tell you when you've done enough exercise. You'll know when you've done enough exercise because you'll feel like, oh, wow, I worked hard today. I did this today. And that's how I feel about a vibration thing that you just put on your body or that you just set on yourself. That if you don't feel like you're getting exercise, you're not. If you feel like you did, if you're like, man, I just walked a mile and a half, I'm out of breath, I can't do this anymore, that's great. Even if it's only 2,000 steps or 4,000 steps, your body feels it. And so that I know you actually did it. But if you walk 10,000 steps, you're like, yeah, I didn't feel like I exercised. You definitely didn't exercise. And that's the same thing with the vibration stuff.
Perfecto. Yo también estoy de acuerdo con usted, doctor. Son sensaciones que el cuerpo, que es muy sabio, te va mandando las propias respuestas, tanto si te pasas como si no llegas, como si te has quedado escaso en el trabajo y en el ejercicio. Hay que saber escuchar al cuerpo también. No sé si hay alguna más. Bueno, relacionado con el dolor, que yo creo que no sé si alguna habíamos dicho, a ver. No, yo creo que están prácticamente, bueno, porque hay algunas que se repiten, ¿no? Que creo que ya están contestadas. Aquí hay una que no sé si se nos ha quedado sobre los cartílagos, que siempre que yo creo que es la pregunta eterna, ¿no? Si un cartílago se puede operar, si un cartílago se puede trasplantar, ¿no? Que sería el futuro, ¿no? De las artrosis y de los dolores. ¿Hay algo sobre cartílagos que se haya avanzado en este trabajo, en este tratamiento?
Yes, yeah, we can. So if you have arthritis in a full joint, you can't really regrow that. But if you have a defect that's like a thumbprint, you know, as part on your knee or on your hip or in your ankle, we can take a piece of cartilage, and there's different ways we can do it. We can take cartilage from cadavers, we can take cartilage from your own bone, we can take cells from your bone and make new cartilage for you, and we can implant that. That all comes with its own risk. Sometimes you can reject the cadaver graft. Sometimes your own cartilage just won't heal in. But we are working towards it, and we have one of my partners here, Tom Minus, does he's like a world expert on cartilage regeneration techniques, and he does those techniques. Now, if your whole knee is full of arthritis, meaning it's just not a thumbprint, but it's the entire knee, the only real solution at that point is a total knee replacement still today. there's nothing new that's changed with that.
Muy bien. Bueno, pues yo creo que dicen que sobre la osteopatía, que al final sí, yo creo que sí que ha respondido, que es un tratamiento, bueno, que es una opción de terapia, ¿verdad? Que no está contraindicada para nada, que incluso alivia en momentos determinados dependiendo del tipo de dolor que tenga, pero que, bueno, no cree que eso vaya a corregir deformidades en las extremidades, ni mucho menos, ¿no? Pero que sí que como alternativa a paliar un dolor puntual, que sí que puede venir bien. Más o menos fue así la respuesta, ¿verdad, doctor? Si quiere matizar algo.
Correct. So, yeah, so achondroplasia aside, if we look at other skeletal dysplasias like pseudochondroplasia, or anybody who has instability in their neck, I would not do any chiropractic treatment to the neck of those patients, or recommend that, because they have instability and that could have a dire consequence. Your thoracic spine, so your back, what we know of as your back, and then your low back, which is your lumbar spine. I think if you're just having low back pain and not having signs that a nerve is impinged, which is pain running down your leg or in the front of your leg, from that, then I think it's fine to attempt it, and it's not going to hurt. It's not going to, there will be no change in deformities of your lower extremities. But, you know, just in general with skeletal dysplasia, if you're worried about the neck not being stable, I would not do anything to the neck in terms of chiropractic treatment.
Sí, vale. Bueno, nada, la gente está animándose, ¿no? Como cada vez más. Tampoco queremos, bueno, yo creo que podemos hacerle la última y un pequeño matiz sobre una anterior.
No, it's okay, it's okay.
Mi hijo Adrián le hicieron corrección de tibias y ahora le queda el fémur. Mi pregunta es, para la desviación de fémur, ¿cuál es el fijador ideal? ¿Intramedular o circular externo?
So it's based on your surgeon's comfort. I like the idea of the intramedullary nail or pin. You can get a decent correction and it's all inside and there's nothing on the outside of their body. If we can avoid this, which is an example of a frame, we try to avoid this as much as possible, but sometimes we just can't. And in some patients with achondroplasia, their bones aren't long enough to have the intramedullary nail or pin. But if we can do that, we can correct deformity. And personally, I think correcting deformity within the femur is much easier with a nail than correcting deformity within a tibia with a nail. And so I think if the surgeon is comfortable that you're going to, then the nail is a really good option. And patients like it so much better.
Sí, siempre está, bueno, la fijación externa o la interna, el grado de corrección que tiene, si es solo para alargar, si también corrigen desviaciones. Yo creo que eso es un tema también muy recurrente, pero yo creo que quizás es lo que usted dice, que eso es un tema a tratar entre profesionales, ¿no? Que quizás nosotros como familias o como afectados o como tenemos ahí menos capacidad de elección, ¿no? Sino que más o menos, ¿no? El experto es el que debe decidir, porque quizás cada paciente, además, cada uno es particular. Lo que le va bien a uno, a lo mejor al de al lado o al siguiente que entra en consulta, aparentemente igual no le viene igual de bien o igual de mal, ¿verdad? Que a veces intentamos generalizar o seguir unos patrones, pero yo creo que cada uno tiene que analizar también, ¿no? Y escuchar la opinión del experto y sobre todo saber que cada uno tiene que analizar su propia condición y su propia situación, entiendo.
Yeah, without a doubt. I mean, there's pros and cons to using all these devices. And some people have a lot of experience with one and not so much experience with the other. And so, you know, they make their decisions because for the most part, I can't say 100%, but for the most part, physicians want the best outcomes for their patients. They're not trying to create harm. They're not trying to create problems. They're trying to fix problems. And in order for them to do that to their best ability, they use the tools that they're most comfortable with. And that's where a lot of the recommendations come with it. Whether you're lengthening with a frame or with a nail, the complications are still the same. You can dislocate joints, the bone may not grow. And so, it doesn't change much there. But it absolutely is a partnership between the physician and their patient in that decision making. And I would definitely not, as a patient, try to force my surgeon to do something. And if you're feeling like go somewhere else, then if you absolutely believe with your heart that this is what you need, then seek a second opinion, because again, your surgeon doesn't want to hurt you. They want to do something together, but it's not good to try to get them to do something they're not comfortable with.
Preguntan sobre los clavos endomedulares, si pueden afectar al cartílago, que eso ¿no? Si llegan a tocar esa placa de crecimiento, ese cartílago, o si pueden afectar a la rodilla también.
So, if you're done growing, no, we don't put the intramedullary pins through cartilage. We put them through spaces where there are no cartilage. Or if there's cartilage there, it's not weight bearing. Your joint doesn't use that cartilage, which sounds bizarre, but it just doesn't use it. Putting a nail through the knee and up currently is probably recommended only in patients that are done growing, but there are instances with patients with achondroplasia where we will recommend, let's just go through the knee, because you're not going to get much growth out of there. And if you have a deformity, we can lengthen it. The other reasons to go from the knee as opposed to through the hip area is if maybe your hip is really stiff and we can't move your hip to get the nail in. So those are reasons. But putting nails in does not damage cartilage. If you go through a growth plate, there could be a chance that it will stop that growth plate. In a child with achondroplasia who's 14 and you're going through their knee, they're probably going to get 4 millimeters out of that growth plate before they're done growing versus 5 centimeters from the nail. So there's really no problem with going through that growth plate at that time.
Bueno, pues yo creo que con esta última pregunta que tenemos aquí, creo que es la mejor como para finalizar la charla, que dice, muchísimas gracias, es usted encantador. Así que yo creo que es la mejor pregunta, ¿no? Como para poner el broche final a esta charla, a este turno de preguntas. La hacemos nuestra también. ¿No? Ha sido un verdadero placer contar con un experto de su nivel.
Thank you.
Para nosotras siempre es un honor teneros cerca, sobre todo sentir que pues ante estas dudas, ante estas segundas opiniones que siempre son tan necesarias, podemos contar con usted y con todo su equipo ahí en Florida, que nos da cierta también tranquilidad y garantía de poder estar ayudando a la gente que acuda a nuestra organización, ¿no? Poder darles toda la ayuda posible en el caso de que sea necesario. Hay gente que no se necesita, pero en el caso de que sea necesario, saber que contamos con expertos como ustedes, para nosotros nos da una tranquilidad y de verdad que es un placer y un honor. Así que entiendo que después de procesar toda esta información puedan surgir algunas preguntas a los espectadores. Yo les digo que pueden enviárnoslo a nuestro email y nosotras se lo hacemos llegar al doctor, y cuando tengamos las respuestas pues también os las devolveremos, ¿de acuerdo? Pues os avisamos por nuestro blog o por nuestras redes sociales o incluso por el email que nos dejéis. Os las devolveremos contestadas, porque toda esta información a veces hay que procesarla y es cuando luego te surgen más dudas, ¿no? Entonces también queda esa puerta abierta para que lo hagáis, ese canal. Así que, muchísimas gracias, doctor Huser, por su tiempo, por su dedicación, por su cariño, y a Kristen también, que seguro que estás por allí, muchísimas gracias por seguir contando contigo. Y a los demás, pues os emplazamos a seguir este ciclo de charlas. Os mandaremos, como siempre, por correo y a través de nuestras redes sociales cuál será la próxima y de qué nuevo experto disfrutaremos. Y cualquier duda, sabéis que estamos a vuestra disposición. Muchísimas gracias y buenas noches aquí. Buenos días al otro lado del charco, como solemos decir aquí.
Thank you very much. Keep exercising. It was
Thank
really a
you.
pleasure. Thank you for having me. Bye.